Thank you to the conference organizers for allowing me to present these data on behalf of my co-authors. I have no conflicts of interest to disclose. Better characterization of PrEP pharmacology and HIV transmission sites within understudied populations of transgender women and non-binary individuals is needed to better understand PrEP's effectiveness in these high-risk populations. However, the resource-intensive processing procedures associated with isolating HIV target cells from tissue biopsies makes these studies very difficult to conduct. We sought to determine whether collecting rectal epithelial cells via cytobrush might offer a simpler alternative by which to study PrEP pharmacology in transmission sites through determining whether concentrations of PrEP's active metabolites and competing endogenous nucleotides were correlated between rectal epithelial cells and rectal CD4 cells, as well as identifying the impact of female sex hormones on this relationship. To this aim, we enrolled 10 healthy premenopausal cisgender females with regular menstrual cycles who utilized contraceptive methods that permit menses on a monthly basis. Participants took 5 directly observed doses of tenofovir disoproxil fumarate with emtricitabine prior to 2 sampling visits that were scheduled to coincide with their early follicular phase, where estradiol is expected to be low, and their late follicular phase, where estradiol is expected to be at its peak. We performed phlebotomy to collect blood serum and endoscopy to collect cytobrush scrapings and rectal tissue biopsies at both visits. We collected epithelial cells from the cytobrush by washing in PBS and isolated CD4 cells from the tissue biopsies by enzymatic digestion and immunomagnetic positive selection. Cells were then counted and lysed in 70-30 methanol water. Estradiol and progesterone were quantified in serum by specific enzyme immunoassay, and PrEP's active metabolites and competing endogenous nucleotides were quantified in cell lysate by HPLC-MS. These resulting concentrations were normalized to cell count and reported in femtomole per million cell unit. The demographic characteristics of our study sample are provided at the bottom of this slide for your reference. Here I'm showing estradiol concentrations on the y-axis by cycle day on the x-axis for each study participant. Their method of birth control is categorized by color. Those using abstinence, condoms, or female-only partners are in pink. Those using 21+7 combined oral hormonal contraception are in blue, and 2 participants using a non-hormonal IUD and a NuvaRing are in black. The median cycle day associated with our first visit was 5, and with our second visit was 15. You can see that for most participants, serum estradiol increases as would be expected as they approach ovulation. Likewise, here you can see that serum progesterone concentrations also increase in most participants as they approach the luteal phase of their menstrual cycle, where progesterone is at its peak. In this graph, I'm showing rectal CD4 tenofovir diphosphate concentrations on the x-axis and those measured in rectal epithelial cells on the y-axis. Blue triangles indicate data points that were collected during the early follicular phase, and pink circles are those that were collected during the late follicular phase. We observed approximately 18-fold higher tenofovir diphosphate concentrations in rectal CD4 cells when compared to rectal epithelial cells, with no correlation between the 2 matrices within or across menstrual cycle phase. For emtricitabine triphosphate, concentrations were approximately 300-fold higher in rectal CD4 cells compared to rectal epithelial cells, and there was no correlation between the 2 matrices. For DATP, or deoxyadenosine triphosphate, concentrations were approximately 10-fold higher and not correlated. And finally, for deoxycytidine triphosphate, concentrations were approximately 10-fold higher and also not correlated. Interestingly, we observed significantly lower tenofovir diphosphate concentrations in rectal CD4 cells when measured during the late follicular phase, shown in this graph as paired concentration data plotted on the y-axis with visit on the x-axis for each participant. These tenofovir diphosphate concentrations were not correlated with estradiol or progesterone, suggesting an indirect mechanism of interaction. Because the late follicular phase coincides with the window of vulnerability when the female genital tract is at a heightened risk of acquiring HIV, further investigation is needed to determine if this decrease is also observed in CD4 cells collected from the female genital tract. Our findings demonstrate that these nucleotide concentrations are consistently lower in rectal epithelial cells when compared to rectal CD4 cells and are not correlated between the two matrices within or across menstrual cycle phase. Unfortunately, the lack of correlation demonstrates that rectal epithelial cells collected by cytobreast should not be used as a surrogate for HIV target cells within HIV transmission sites in studies that are intended to characterize PrEP's pharmacology. With that, I'd like to thank my funding sources and the study participants, as well as acknowledge the exceptional efforts of our friend Heather Prince in executing this trial. Thank you.
Thank you to the organising committee for giving me the opportunity to present my research here today. Lymphoid tissues are a primary site of HIV replication. Antiretroviral therapy results in the effective inhibition of viral replication in peripheral blood. However, HIV reservoirs can persist in tissues. Continuing viral replication has previously been linked with subtherapeutic concentrations of antiretroviral drugs in the lymphoid tissues, and lymphoid tissues can represent a reservoir of inducible virus. Understanding the degree in which antiretrovirals penetrate lymphoid tissues could be pivotal in optimizing therapy and reducing the latent reservoir. The objective of this study was to incorporate lymphatic physiology in a whole-body physiologically based pharmacokinetic model to describe the penetration of antiretrovirals in lymphoid tissues. A generic schematic of the PPK model can be seen in the diagram on the right, where individual organs are represented as single tissue compartments, which are connected by the cardiovascular system. The lymphatic PPK model was created from a previously published adult PPK model. Specifically for the lymphatic model, each compartment was further divided into a vascular, interstitial, and tissue compartment to better characterize drug movement and has been illustrated in the diagram. The model is set up such that the arterial blood compartment receives blood from the lung compartment and distributes blood to all vascular compartments. Each vascular compartment is connected to its respective tissue and interstitial fluid compartment. Lymph flow-driven drug movement from the tissue compartment to the interstitial fluid compartments was also included. Lymph from all the organs is delivered to a central lymph node compartment via the efferent lymph supply from the interstitial compartments. Lymph flow is then delivered to the renal compartment from the lymph node, completing the circuit. Parameters such as lymphatic flow, interstitial fluid, and vascular capacities were used to describe the physiology of the lymphatic system and were derived from the literature. Moving on to the validation, the PPK model was qualified against available literature data describing the lymphatic tissue to plasma penetration ratios of raltegravir and efavirenz. Physical, chemical, and biological characteristics such as log-P, pKa, and intrinsic clearances were utilized as input data to simulate the plasma PK profile of both drugs. Certain drug-specific parameters such as fraction unbound in plasma and fraction unbound in tissue and blood-to-plasma ratios were used to determine lymphatic penetration. 100 healthy patients were simulated over a 30-day period for both drugs, and mean PK parameters were recorded for comparison and have been detailed in the table. Efavirenz 600 mg once daily and raltegravir 400 mg twice daily were simulated, with mean AUC, Cmax, and Ctrough values yielding absolute average fold error values well within the twofold acceptance criteria. Moving on to the prediction of lymphatic penetration, the graph on the left describes the average daily concentrations of both drugs in plasma and lymph, and on the right we have the penetration ratios. The observed lymph-to-plasma penetration ratios of raltegravir and efavirenz were reported as 1.49 and 2.28. In comparison, the simulated ratio for raltegravir was 1.42 and for efavirenz 1.97. As you can see, the model is in good agreement with literature values and can appropriately describe the penetration of raltegravir and efavirenz. To summarize, quantifying antiretrovirals in lymphoid tissues can help optimize antiviral activity. The lymphatic model shown here today can be particularly useful when coupled to a pharmacodynamic model describing viral kinetics and can generate information that can be used as input data for such PD models. This kind of coupled mechanistic modeling technique can be used to develop new antiretroviral dosing regimens that strategically target the HIV reservoir, marking the foundation for working towards a potential cure. Lastly, I'd like to say thank you to the members of my research group at the University of Liverpool.
Thank you to the conference organizers for allowing me to present our data on behalf of my co-authors. I have no conflicts of interest to disclose. EFDA is a potent nucleoside reverse transcriptase translocation inhibitor, which exhibits favorable pharmacokinetic characteristics for long-acting formulation and has been investigated in a drug-eluting implant for HIV pre-exposure prophylaxis. EFDA is intracellularly phosphorylated and inhibits HIV integration via multiple mechanisms, including immediate or delayed chain termination following EFDA triphosphate's incorporation into the nascent DNA strand in place of the endogenous nucleotide DATP. Thus, the validity of preclinical safety and efficacy assessments relies on the assumption that EFDA's intracellular pharmacology is consistent across species. We hypothesized that EFDA was differentially phosphorylated among species commonly used for preclinical models in drug development, with a goal to identify which preclinical models most closely match the intracellular pharmacology of humans. We isolated peripheral blood mononuclear cells from whole blood of 6 species via phi-col separation and using a red blood cell lysis. We incubated 1 million live PBMCs in 0, 5, 50, or 500 nanograms per mil EFDA in triplicate for 24 hours under standard culture conditions. We then removed the treated media, washed with PBS, and counted PBMCs in a representative control well on a hemocytometer using trypan blue staining to characterize viability. PBMCs were then lysed in 70-30 methanol water. EFDA triphosphate and DATP were quantified by HPLC, MSMS, and resulting concentrations were reported in F moles per million live cell units based on the representative count. All species exhibited cellular viability above 87% at 24 hours of culture, except for rabbit, which was approximately 34%. I'm showing EFDA triphosphate concentrations plotted on the y-axis across dosing levels on the x-axis for human PBMCs, which have been quantified across 3 dosing levels. Non-human primates and rat also exhibited quantifiable concentrations across all 3 dosing levels, but were approximately 1.8 to 15-fold lower than humans, respectively. Natural log transformed EFDA concentrations increased particularly with natural log dosing. In these 3 species with R-squared values above 0.7. Additionally, human and non-human primates exhibit the most similar relationship between concentration and dose, with a linear regression line slopes of 0.89 and 0.85 respectively. For mini pig, we were able to quantify EFDA triphosphate concentrations at the 50 and 500 dosing levels that were approximately 46-fold lower than human. For dog and rabbit, we were only able to quantify EFDA triphosphate concentrations at the highest dosing level that were approximately 110 and 780-fold lower than human, respectively. Here, I'm showing DATP concentrations plotted on the y-axis, grouped by species on the x-axis. The lines through these box plots are the median. Box edges are 25 and 75th percentile, and the whiskers are 10th and 90th percentile. Non-human primate, mini pig, and dog DATP concentrations were significantly higher by 2 to 10-fold when compared to humans, while rat was significantly lower by 4-fold. We did not make this comparison for rabbit due to the poor cellular viability after 24 hours. We found that EFDA's intracellular pharmacology significantly differed between species. While the degree of phosphorylation was most similar between non-human primates and humans, EFDA's computing nucleotide DATP was approximately 10-fold higher in non-human primate, which could result in lower potency when compared to humans. While EFDA triphosphate concentrations alone were lower in rat, the relationship between the EFDA triphosphate and DATP was more similar to humans. Given these rat data, similar studies should be conducted in mice to determine whether humanized mice might be the optimal efficacy model for EFDA. One limitation of our study is that we only explored EFDA triphosphate and did not characterize intermediary compounds such as EFDA monophosphate, because structural activity relationship studies between EFDA monophosphate may be pharmacologically active. This more complete characterization is warranted. I'd like to acknowledge my funding sources listed here, and I'm happy to take any questions.
Good evening to everyone, and it's a pleasure for me to present our work at the International Workshop on Clinical Pharmacology, from the title Inflammation Effects, Antiretroviral Plasma and Intracellular Exposure. starting from the fact that the aim of antiretroviral therapy is to maintain a virological suppression in our patients and to promote immune recovery. We all know that most of the drug targets are at the intracellular level, but yet the association of intracellular concentrations with the efficacy and tolerability of the regimens is not completely known. So some authors previously showed that during chronic inflammation, there is a higher expression of some membrane transporters, such as glycoprotein pre or organic anion transporters. And additionally, these lower intracellular penetrations within PBMCs or tissues have been observed with this higher expression of these transporters. So the group of Fletcher showed that limited penetrations of antiretroviral drugs within tissue brings to the persistence of the immune sanctuaries as a potential mechanism of viral persistence and chronic inflammation too. So for that reason, aim of our study was to investigate the correlations between the plasma presence of inflammation biomarkers and the plasma and intracellular exposure of some of antiretroviral drugs in our HIV-positive population. For that reason, we included in our study 60 adult patients on a stable heart and all virological suppressed at the time of the analysis. Most of them were male, 80%, with a median age of 53 years old and a normal BMI. We divided in 3 groups, 25 on a triple therapy and a dolutegravir as the third drug, 9 on a dolutegravir-based dual therapy, plus the protease inhibitors such as darunavir and atazanavir boosted with cobicistat, and 26 patients as the third group on the triple therapy and the darunavir cobicistat as the third drug. We measured 4 different inflammatory biomarkers such as CRP, interleukin-6, CD14 and LPS, and we compared in the 3 groups. We performed the correlation at last between these inflammation biomarkers and antiretroviral drug plasma and intracellular concentrations. As you can see in the table, there were no difference among the 3 groups of these 4 inflammation biomarkers. As far as concerned the correlations between the antiretroviral drug, plasma, and intracellular exposures with the 4 different inflammation biomarkers, they are reported in the table above, where we did not observe any statistically significant correlations between the dolutegravir intracellular plasma or intracellular plasma ratio. But if you look at the darunavir plasma correlations, we found a positive correlations that tend to be significant with the CD14 as reported in the graph on the left, and the inverse correlations statistically significant between the darunavir intracellular plasma ratio and interleukin-6 as reported in the graph on the right. But we wanted to study the dolutegravir concentrations when dosed with the boosted therapy on the dual therapy, as reported here in the first column, versus the dolutegravir dosed in the unboosted regimen dosed with the triple therapy. And we found correlation and inverse correlations between dolutegravir in the unboosted regimen that was tend to be significant with the CD14. And as you can see in the graph on the left, in the boosted regimen, there was no correlation at all with the CD14. So to conclude, we observed a lower darunavir and the dolutegravir in the unboosted regimen intracellular penetrations, together with a higher expression of some inflammation biomarkers. So our data support the hypothesis of a concrete interplay between a chronic inflammation and the antiretroviral penetrations within PBMCs. The molecular mechanism need to be further studied. They are not still clarified, but to understand the effect of a chronic inflammation and the penetrations within tissues within PBMC or the modern antiretroviral therapy can be very important and relevant for the choice of a correct antiretroviral regimen, can be even included in the immunomodulating strategies. And with this, I want to thank all my collaborators and you for the attention.